So in this part, we are going to discuss our case number 3, which is intended to let you know the clinical based questions important for your NEET PG and INI-CET. So this is Dr. Shivaam, and let us see our case. A 53-year-old gentleman presented with a slowly growing lesion at the right angle of the jaw. Histology following a superficial parotidiectomy showed a Warthin's tumor that was completely excised. He presented after 2 years following surgery with complaints of sweating on the right side of his face when he eats. So here in this picture, what all we can appreciate is, we can appreciate a parotidiectomy incision. You can say a Blair's incision. So the incision that we give in a parotidiectomy or superficial parotidiectomy is S-shaped or lazy S incision, also called as modified Blair's incision. Why modified? We have modified this incision so that it doesn't make an acute angle in the postauricular region. Why? Because if it is acute angled, the flap that we raise for removing the tumor becomes necrosed. That means there are high chances of flap becoming necrosed. So always remember, the angle that we make here is always an obtuse angle and not an acute angle, right? So this will help us to the vascularity of flap, to maintain the vascularity of flap. Now coming to the question, what is the likely diagnosis, how would you diagnose it, and what are the available treatment options? Now if we see from the history only, we are getting a peculiar history of sweating on the right side of face, which is seen in post-operative phase. So post-operative, after superficial parotidiectomy, you all know that there is one syndrome that might occur, and that syndrome is auriculotemporal syndrome or Fraze syndrome. So we all know that post parotidiectomy there are chances of sweating developing in the area of parotid, and that is called Fraze syndrome. So why it develops? This is basically due to aberrant innervation of the sweat glands that are overlying the parotid gland. And why it happens? It happens because during surgery, when we raise the flap, the sympathetic supply to the sweat glands become disconnected, and what happens is, during healing, these postganglionic parasympathetic fibers, they join and innervate these sympathetic sweat glands, right? Now whenever there is stimulation of these nerves, these are causing the sweating from the region of parotid. That means whenever parotid was responsible for salivary secretion, so whenever there is salivary stimulation, that same stimulus will cause stimulation of these cutaneous sweat glands, and that will result in sweating in the parotid region, right? So there is localized sweating during eating or salivation. So incidence of Fraze syndrome varies widely. It depends, and we can use several methods to prevent these syndromes in postoperative phase. So what we need to do is, we can minimize this risk by interposing the gland capsule with, or by interposing or giving some autologous tissue or some material or some muscle between the flap and the gland, so that these aberrant innervation of the parasympathetic nerves do not happen with the sympathetic sweat glands. And if this connection, this aberrant innervation doesn't happen, there won't be any sweating during salivation. Now coming to the second part, how you are going to diagnose it. So there is a test called iodine starch test, and what you do in this, we usually paint the parotid region with the iodine and then wait for the iodine to get dried. Now what we do is, we sprinkle the starch over the parotid region. So iodine is painted but dried, and we have sprinkled the starch over that painted region. Now what we do is, we give patient a salivary stimulus. So basically we give something that will stimulate the salivation for the patient, something delicious or sweet dish or anything, and this will cause the salivation to stimulate, and in turn, if there is Fraze syndrome present, it will cause sweating, and sweating will cause this dried iodine to become wet, and iodine when mixed with starch will give us a pigmentation. So that will prove us that Fraze syndrome is present. Now coming to the treatment, so you should only know that at this present moment that iodine starch test is used for detecting Frey syndrome in postoperative parotidiectomy patient. For treatment for mild symptoms, usually we do not do anything, but if the symptoms are problematic, then there are different surgical and non-surgical options available. So what you can do is you can prescribe some topical anticholinergic or antihydrotic. We can give botulinum A toxin, which is popular but a temporary treatment. Surgical options include excision of the affected area or tissue interposition. That means between the flap and the parotid you will interpose some tissue. These procedures, however, have a risk of facial nerve injury, but this is what we have at present. Now coming to our next case, which is a 74-year-old patient presenting with 6-month history of a painless lump between the earlobe and the angle of jaw. So this is our angle of jaw and this is our earlobe. So somewhere here is presenting with a lump and there is no skin changes or recent change in size. So let us see what our examiner wants to ask. The examiner wants to ask, what is the differential diagnosis at this region? How would you investigate this lump? What are the treatment that you can offer and what consent issue you would discuss prior to surgery? Now if you see this region is particularly a region where you can suspect a parotid swelling. So this is most likely a benign parotid tumor, and if you see the incidence of benign parotid tumor, you will observe that pleomorphic salivary adenoma constitute 80% of these benign parotid tumor. So this can be your most likely diagnosis. If you ask me other DD, it can be Warthin's, that is adenolymphoma, it can be any lymph node, and it can also be malignant mass metastasis or hemangioma. So most useful investigation that your examiner might ask you will be, your next investigation will be, or most useful investigation is FNA. Your next investigation can be a ultrasonography, but most useful investigation that will give you an idea of diagnosis with an accuracy of greater than 96% is FNA. Imaging with either USG or MRI is complementary but not essential in benign disease and reserved for patients with red flag symptoms such as recent increase in size, skin involvement, and fixed hard mass or facial nerve weakness. That's why in question they had said that the size is constant. Now, if the cytology reveals pleomorphic salivary adenoma, you can do a superficial parotidectomy in that patient, and you have to counsel the fact that there is 2 to 10% of chance of malignant transformation if it is observed for long period. So patient might ask you that it is benign, why you are going to operate? So there are chances of it turning into malignancy, that's why it's needed to remove this tumor. Now what consent you will keep in mind? So this point is very important for you all, because as you get into your residency and even in internship, before operation you should know what all medical legal consents you need to take before taking your patient to operating theater. So you should mention the risk of temporary or permanent injury to the facial nerve. Why? Because facial nerve is the nerve which is lying in your operative field, very much close proximity to the tumor. So that's why you should tell the patient about the possible complications that might occur. Numbness of ear lobule, scarring, soft tissue defects, salivary fistula, seroma, infection, Frey syndrome, recurrences are the other things that you should discuss with your patient, right? So enucleation, apart from selected cases of warting and lymph node, is not indicated for pleomorphic salivary adenoma. You have to make the patient undergo a superficial parotidectomy or a partial superficial parotidectomy. So this is some important cases that I wanted to discuss with you, and you will find more of such kind in our app that you should download and stay connected with me. You can also WhatsApp your number to my number so that I can keep on sending you the relevant important things that I find that you should know before you attempt your examination, right? So your INI-CET is very near. I hope that you won't get panic and will give your 100% into it. Just remember that The preparation that you have is more than enough. Do not get fear about others, because whatever they have studied, they will be getting their marks. Whatever you have studied, you will be getting your marks. So there is no need of thinking ki that person have studied that much and hamper your own study, right? So you should have confidence in the things whatever you have read, and remember that those are more than enough. You will be able to answer, you will be able to remember the things in your exam. Keep this confidence with you, it will help you in the final run. So in the last, let us see one more question and we'll end this video. So a 59-year-old male electrician referred with a 3 months history of worsening dysphonia. So there is change of voice which is worsening progressively. Comorbidities include hypertension, and he had smoked 30 cigarettes per day for 40 years, drinks 40 units of alcohol per week, and you are being given a flexible nasoendoscopy which is revealing a lesion on the left vocal cord. Although the cord mobility is normal, there is no neck node palpable. Direct laryngoscopy at the time of biopsy shows this. What is the diagnosis? Most common subsite of this pathology, TNM classification and treatment option. So seeing this, you are pretty clear that this is an exophytic keratolytic lesion on the left vocal cord, most likely a squamous cell carcinoma of the larynx. Why so? Because all the high risk features were present. The look of the white exophytic keratotic lesion is not good, so it is probably a squamous cell carcinoma of larynx. The lesion is increasing in size, the worsening or the dysphonia is progressive. That's why our diagnosis of squamous cell CA. Although for confirmation we need a biopsy. So glottis is the most common subsite, accounting for 50% of the tumor. 40% arise in supraglottis and 10% in the subglottis. TNM classification is something you all should know, and it is relatively easy for you all, so you should go through it. We'll just give you an overview or idea. The T1, T2, T3 and T4. T1 further divided into T1A and T1B. T1 is tumor limited to vocal cord. Now if it is one vocal cord, it is T1A. If it is two vocal cord or both the vocal cords, it is T1B. Coming to T2, if the tumor is extending from glottis, so assume this to be glottis, if it is extending from glottis to supraglottis or subglottis, right, or if there is impaired vocal cord mobility, right, the thing that you have to note is the vocal cord mobility is impaired and vocal cord is not fixed. Whenever in question you get that vocal cord is fixed, it should be minimum of T3 stage. So when the tumor is limited to larynx with vocal cord fixation, so this term you would only get when it is T3 or above, right, or it invades paraglottic space, minor thyroid cartilage, etc. Now T4A and T4B are something which is advanced. So tumor is invading into the thyroid cartilage, invading the tissue beyond the larynx like trachea, soft tissue, including the deep muscles of the tongue, strap muscle, thyroid, oesophagus. So these are T4A. If it is involving the adjacent structures like thyroid, oesophagus, strap muscles, extrinsic muscles of tongue, trachea, soft tissue of the neck. T4B is something which is very different. That means it has progressed to an extent that now even the surgery is sort of difficult or inoperable. Now the tumor is invading the prevertebral space, encasing the carotid artery or invading the mediastinal structure. So most of these cases are inoperable. That means T4B can be labeled as inoperable stage, where the tumor is invading the prevertebral space, encasing the carotid artery or invading the mediastinal structures. So I hope you won't forget this T classification, and with treatment you should know that there is usually these early laryngeal malignancies are treated with single modality of treatment. So there are different modality of treatment like radiotherapy and surgery. So either you will do radiotherapy or you will do transoral laser microsurgery or transoral robotic microsurgery. Right now, comparing this treatment, which one you will give? So surgical resection without the use of laser has been shown to decline over the past decade. So that's what is the treatment of choice. You can say transoral laser microsurgery, which is the mainstay of surgical treatment. Now why not radiotherapy? Actually both radiotherapy and transoral microsurgery, they both have somewhat equal, or you can say the laser microsurgery has higher rates of long-term laryngeal preservation compared to radiotherapy, right? Also, radiotherapy has a drawback in younger patients. Why? Because of side effects of radiotherapy can be significant. So you have to decide depending upon the patient's age, the risk factor, and the results that the patient want between radiotherapy and transoral laser microsurgery. But these things you should know that these are the different modalities, and finally the treatment should be discussed and a multidisciplinary team approach should be there to decide treatment on individual basis for every patient. So I hope you all are getting these important things, and somewhere it is going to help you a lot in your clinical scenarios and getting the concepts for your main exam, that is NEET PG and INI-CET. So this is Dr. Shivam, hoping the best thing happen for you, and till then stay happy and stay healthy.